My name is Wes Roach. Tonight we're going to talk about a topic very dear to my heart, cranial cruciate ligament tears in dogs. I think it's a massive topic. We're going to try to just focus on some important stuff, that, all these stuff that I think is important. Can everybody hear me okay? All right. So first off, I just want to kind of go over the reason I'm talking about this tonight. First off, cruciate tears it's very prevalent. It's one of the most common causes of lameness in dogs. It's unique in that, unlike hip dysplasia and elbow dysplasia, medical therapy is actually not recommended for cruciate tears. Surgery is the treatment of choice. In 2006, there was an article in the Wall Street Journal that said there were, I guess, over 1.2 million ACL tear surgeries in dogs in the U.S. And that was in 2006. This is 5 times more than the number of human ACL surgeries that same year. And I find that interesting because there's apparently humans outnumber dogs 5-1 in the U.S. So there's just a huge number of dogs, huge proportion of dogs that have ACL tears and are going to surgery. So this is a very big topic. Also, the economic impact of ACL tears in dogs. In 2003, there was a study showing that it was over $1 billion per year industry. And that was 10 years ago. So I'm sure it's significantly more than that now. That's related to how common it is and also how expensive some of these surgeries are. And then finally, I think it's a unique topic because there's so many different surgeries that are out there, and these dogs can do so well with all of these surgeries, and no one really can agree on what is the best surgery out there. It's kind of a confusing issue. And so hopefully we'll kind of go through some of those procedures tonight. Look at some of the evidence that's out there, and maybe realize the lack of evidence that's out there. And if you have any questions, feel free to ask questions along the way. One thing I wanted to mention is that the handout's going to be different than this, a little shorter. I did this talk last night. It took about 2.5 hours, so I cut off just a few slides. So if a slide's missing off your sheet, or the other way around, that is why. So an overview of the talk tonight, we're going to start out with just some basic anatomy. We're going to talk a little bit about how dogs may present to your clinic, how to diagnose ACL tears, really get into partial ACL tears. I think it's an important part of the ACL tear complex. And then we're going to talk a lot about lateral sutures, kind of get into that. If you guys have any questions about that, please, as we get to it, just ask. We're going to take a short break, and then we'll get into kind of the cool stuff. Talk about TPLOs, TTAs. And then I want to present kind of the more recent articles that are out there. What is the clinical evidence for some of these surgeries, like lateral sutures, TPLOs? And then we'll end with some concurrent abnormalities these guys can have, so like meniscal tears, MPL, stuff like that, that may change how you may approach the ACL tear surgery. So first off, just starting with some basic anatomy. This is a craniocaudal view of the stifle. Had the femur, the tibia, the fibula. Then you have the cruciate ligaments, the cranial cruciate ligament, and then the caudal cruciate ligament. The cranial cruciate ligament comes from the axial aspect of the lateral condyle, and it goes from caudal to cranial and attaches to the cranial aspect of the tibia. So just so we're all clear, the cruciate ligaments kind of cross in the middle of the joint, and they're named by where they attach on the tibia. So even though the caudal cruciate starts cranial, it goes caudal. It's named the caudal cruciate, just so we're all clear on that. The functions of the ACL, there are 3 main functions. The most important one by far in the dog is going to be limiting cranial drawer, cranial tibial translation. That's because dogs stand in that kind of semi-crouched position. People, we stand straight up. We kind of lock our knees out. We don't really use our ACL unless we're doing something athletic. Dogs, they stand in that semi-crouched position, just load that ACL constantly. So it's more, when we get into why they tear their ACL, it's more of a wear and tear injury than kind of the traumatic injuries that you see in people. So that's the main one, limiting cranial drawer. The second function is that it limits internal rotation. So where this may be important to some of these dogs is they may have a patella luxation. They've had a patella luxation their whole life, and now their patella luxation, they see more lame on that leg, and maybe the patella luxation is actually worse, went from a grade 2 to a grade 3. That may be an indication they've torn their ACL, because now their tibia can internally rotate once they've torn their ACL. And then the third function is limits hyperextension of the stifle. Where that comes into play is on your physical exam. You can look at each one you can evaluate each one of these functions on your physical exam just to kind of give you some clues. Does this dog have an ACL tear? Is it a complete tear? Is it a partial tear? So why do dogs tear their ACL? Like I was mentioning just a second ago, there's all these things that people have proposed. A lot of folks come in, a lot of owners come in and think their dog has just acutely torn their ACL. It's been shown that trauma, as far as causing ACL tears, they go from a perfectly normal cruciate ligament to completely torn. That happens in about 10% of the cases, so pretty low numbers. The most common scenario is they have this chronic degenerative process that goes on. It's kind of this, over time they'll kind of slowly tear a couple fibers, and then eventually they'll tear completely. And so when we get into the history, you'll find most owners, if you ask them, they'll say, my dog has had, maybe a couple months ago we were lame on that leg, kind of picked it up for a day and then put it back down. Most owners will be able to recall that. Other causes besides the chronic degenerative process, breeds, genetics. In the Newfoundlands, it's been shown to have a genetic role for ACL tears. The Labrador, Rottie, and Newfies have a higher odds ratio of having a cruciate tear than other breeds. And then increasing age, obesity, some joint inflammation, all these things can contribute to the structural damage of the ligament. There is some evidence of immune-mediated disease or infectious components with cruciate disease. I think it's important to realize that the cruciate ligaments, both the cranial and the caudal cruciate ligaments, are extrasynovial. So they're in the joint between the femur and the tibia, but they're covered by synovium, so they're not actually in the joint. So once you have some trauma to those ligaments, then it's exposed to the joint. You kind of get an immune reaction to that. So that might be part of the complex that's happening here. But overall, I think it's, when you're talking to owners and they're trying to figure out what happened, I think you just tell them it's a multifactorial cause for cruciate disease. We don't actually know. All of these things kind of filter into the dog presents with a torn ACL. What are you going to do? We'll talk about surgery here in a second. Another category for causes of ACLs, ACL tears, is conformation of the pelvic limb. We see quite a few dogs that have patelloluxations, or they have real bow-legged conformation. And these are things you want to pick up on because you may want to correct that at the same time you correct the ACL. Also, tibial plateau angle, or TPA, as you can see in this radiograph, this being the tibia here, the femur's up here, this dog has a tremendous tibial plateau angle, probably high 40s, maybe 50 degrees, where most dogs have about half of that. And so we'll talk a little bit about how that may contribute to ACL tears. So let's get into how dogs may present to your clinic. Kind of a classic history with ACL tears. And let me just back up. I'm going to use ACL, cruciate, all those things interchangeably. If that gets confusing, just let me know. I usually call them ACL tears. The classic history is that you have an acute, either toe touching or non-weight bearing rear leg lameness. And like I was saying before, most owners, if you sit down and listen to them give their story about how the dog jumped off the bed and tore his ACL, once you get past that and just really start asking about the lameness, they'll usually recall a couple instances where the dog's been lame before. And that kind of fits with that chronic degenerative process, kind of slowly breaking over time. Because rarely when you get to surgery is it this acute tear. It's usually all these chronic changes, the ends of the fibers look like they've been torn for a long time, but they have this acute history. Owners may notice that their dog sits differently. Instead of sitting with their legs up underneath, they may kind of kick a leg out to the side, kind of like this picture here. It's called the sits test, and it's kind of an indication that maybe the problem is in the knee rather than the hip. Also, they may notice the dog shifting weight off the leg. So when they're standing, maybe not holding it up completely, but just kind of tapping it down. Those are all kind of indications that maybe this is going to be an ACL tear versus like hip dysplasia, something like that. I always tell owners this. Dogs in general are three-legged animals with a spare leg. All right. If they hurt one leg, they're going to pretty much pick it up and just take off running, chase the ball, whatever they normally do. When you get the history the dog can't get up, struggles to get up, that usually means there's more than one leg involved. So maybe they've torn both ACLs, maybe they've got something else going on in a different leg. So that's something to know. I would say overall with the history, it's really tough to find a scenario with a rear leg lameness where you shouldn't check for an ACL tear. Sometimes they'll come in, we've seen dachshunds that come in down in the rear. That's actually bilateral cruciate disease. You know, just all of these dogs, and they talk about ataxia in their rear legs, weakness. You should check, check for ACL tears on all these guys. All right, so physical exam findings. I would say if you only take one thing home from tonight's talk, let it be this. I would say diagnosing ACL tears is way more than just checking for drawer. All right, you should have it, in my opinion, you should be able to diagnose if the dog has stifle disease within about 5 seconds of touching the dog. Before you lay him down, before you check for drawer, that's my goal, to get that point across tonight. And if you have any questions about that, come up to me after. I'll be happy to show you how to efficiently check for stifle disease. So to me, the standing exam, this is the most important part. Most dogs will tolerate a standing exam. Not all dogs tolerate the laying down exam. Sometimes you have to sedate them. They're kind of worked up. But the standing exam is I think very easy. And I'll go through that here in a second. In fact, first we'll show you a little video. So this is going to be a video of a standing exam. I think this is probably the most important 5 seconds of your orthopedic exam, I think. What I'm going to be doing here is there's going to be a dog standing. I'm going to be standing behind the dog. And we're going to be palpating both back legs at the same time. I'm going to put both my index fingers on the patella tendon, feel for effusion, and then the proximal tibia and feel for medial buttress. And that's pretty much all you got to do. So all I'm doing is just standing behind and feeling both knees, feeling for buttress. I think this is the most sensitive way to feel for buttress because you can compare both legs at the same time. Okay, you can kind of feel, some dogs kind of have a real prominent proximal tibia. It can be a little confusing if it's buttress or just their conformation. So if you feel both at the same time, then usually it's easier to feel. But I think that right there, if you just practice that, I don't know if you guys already do this or not, but this is the most helpful thing I've found, is a standing exam. At the same time, when they're standing, you can feel for muscle atrophy and see if they have less muscle on one side versus the other. And then, of course, when most people think about testing for ACL tears, that's when you lay them down, you feel for cranial drawer, tibial thrust, all those things. And I have a couple of videos of those as well. Does everybody feel fairly comfortable with cranial drawer, tibial thrust? I can go through in some severe detail if you like. But this first one's going to be the cranial drawer test. And the anatomy is your top hand always goes on, your index finger of the top hand goes on the patella, your thumb goes on the fibula, and then the bottom hand, the index finger goes on the tibial crest, and your thumb goes on the fibular head. And what I've seen folks do is really just try to crank on it, try to throw it forward, like they're going to actually tear the ACL doing it. What I recommend is just gently hold it and just go back and forth, let the dog relax, and then see if you have drawer or not. So putting the top hand positions, feeling for those bony landmarks, putting the bottom hand on, and then just gently feeling for drawer. You try to do an extension and also in flexion. And then for the tibial compression test, this is maybe a little bit more confusing. I know when I was coming out of vet school, I didn't really understand what this test was. And it took me a while to kind of figure it out and kind of perfect it. But the idea is you're extending the stifle. So you're taking the palm of your hand and just pushing on their stifle to extend it. Your index finger lays across the patella tendon. The tip of your index finger touches the tibial crest. And then with your other hand, you're simulating weight bearing by flexing the hock. So I'm putting the top hand on, the palm of my hand over the stifle, keeping that in extension, and then I'm flexing the hock. What I'm testing for is, does that tibia slide forward? And cranial drawer, does it slide forward? If it does, you usually pick it up with your finger. And I find in some dogs, it's dramatic. It just kicks forward. In other dogs, it's not obvious at all, but they have plenty of drawer. So I used to do both tests on every dog. I think in general, ACL tears, if they're complete, are pretty much straightforward. Usually you can diagnose it on a physical exam. They've got this instability in the knee. I think this is kind of a whole different thing, but just as important. Okay, the partial ACL, a little bit harder to diagnose, but just as important clinically. Surgery is the treatment of choice for partial cruciate tears, and so it's important that you can pick up on that before it takes them 6 months to completely tear it. If you could pick it up that first week and have surgery, maybe prevent some of the arthritis that goes along with with waiting for surgery. So the key with partial cruciates is to realize that ligament is never going to go back to normal. It's never going to get better. What will happen is the joint will try to stabilize the knee on its own and put some scar tissue down, but the ligament itself is just never going to get better. It's a chronic source of pain, inflammation, you get progression of DJD. Most of the partial tears will eventually become complete tears, but I would say in the boxer, and maybe some German Shepherds, you get this chronic partial tear. So you never get that drawer. But they get these real big, thick knees. So this is specifically in boxers. If they get a big, thick knee, I'd send them for surgery. I mean, it's going to be a partial tear of the ACL. So that's something to just realize that that's happening. How do you diagnose a partial tear? You want to do the same test you did before. I think the standing exam is very helpful. You're feeling for a fusion, you get the buttress, but you don't get the drawer. So you can either take that information, do a radiograph, confirm yes, there's stifled effusion, yes, there's DJD. I think it's a partial tear. Let's go to surgery and find out. You can do that. I think another part of the physical exam is to test for hyperextension. Like I was saying, as far as functions of the ACL, one of the functions is to prevent hyperextension of the stifle. And so if you hyperextend their stifle and they have a partial tear of their ACL, they're going to let you know that hurts. And I usually compare one side to the other. I think it's a great test. I was not taught this in vet school. I think it's a very important part of your orthopedic exam is doing the hyperextension of the stifles. I think we have a video of this. So kind of the same thing. I'm just gonna hyperextend that stifle. I'm not trying to rip his knee off or anything, but I'm just hyperextending, okay? Does everybody do that test? Is that part of your routine physical? I don't know what they're teaching you guys these days. All right, so diagnostics. As you can tell, the first three diagnostics would be the physical exam. I think it's the most important part of diagnosing ACL tears. It is the rare case where you have to go to the X-rays or go to do something extreme to figure out if it's an ACL tear. You should pretty much know off your physical exam. They have stifle disease, and almost always stifle disease is going to be the ACL tear, or at least a partial tear in a dog. If the dog is real nervous or aggressive and you need to sedate them, then I would say the sedated exam is maybe my next choice. So the sedated physical exam. So the top four is going to be your physical exams. For sedation, we use a lot of dexdomitor cocktails, maybe some dexdomitor butorphanol. I prefer to give it IV. I think it has a much faster effect rather than when you give it sub-Q or IM, come back in 15 minutes, they're still awake. You give another dose, and you kind of keep doing that until it all kind of kicks in at once. Then you have this dog that's just in a coma. We prefer to just give it IV and then reverse it once they're done. For the kind of less healthy dogs, we use the butorphanol ACE combination. The advantage of that is, in my experience, you cannot kill a dog with butorphanol and ACE. They might sleep for a while, but you're not going to kill them. They're going to wake up eventually. But in the healthier dogs, we use dexdomitor pretty frequently, and it works well for the sedated exam. You may also find some of these dogs that you're having to sedate to lay them down to check for drawer, check for thrust. You can just do a standing exam. You can do the cranial drawer and tibial thrust test while they're standing, and that might be an easier way on the dog. And so this is a cool little test. It has to be the right size dog though. What you do is I usually, if I'm dressed up like this, I'll put a little towel on my knee, and I'll just pick the dog up and put them on my knee, take the weight off their back legs, and then just do the drawer test or the thrust test with them standing. Kind of sit them up on your knee like that, and then just check for drawer that way. I think I have a video. Same thing. We'll just check for tibial compression. Does anybody do this? Am I the only person that does this? I think it works well. Like I said, it has to be the right size dog. Sometimes it's a big Great Dane that's not going to happen. All right. So back to the diagnostics. Once you get your physical exam done, I think every dog that's going to go to surgery needs X-rays. 2-view X-rays always. And reasons for that would be, one, to support your diagnosis. You see inflammation. So on this X-ray, it's a lateral view of the stifle. I have the femur here, the tibia coming down. This dog has effusion, cranial and caudally, has quite a bit of DJD coming off the patella, off the femur, off the tibia here. One is just confirmation of what you're feeling on the physical exam. But two, we want to rule out other diseases. We've had a couple dogs that come in for ACL tears, and yes, they do have an ACL tear. They also have a bone tumor in their femur. It's nice to know that before you take them to surgery. They can also rule out, angular limb deformity. Some of these guys have some real weird anatomy, or they'll have an OCD lesion causing all this, effusion. Those are things you can pick up on X-rays. So, in my opinion, every dog is going to surgery, 2-view X-rays of the stifle, always. And if you're putting in implants that are radiopaque or you're putting in bone tunnels, they should have 2-view post-op X-rays as well to document what you did. I think that's the way to do it. Other diagnostics, arthroscopy. It's a valuable diagnostic, especially in dogs that have partial tears where you're confused. What's going on? Let's just pop in and take a look at the ACL, just confirm it is a partial tear before proceeding with going in, doing a lateral suture or doing a TPLO. I don't think it's really necessary in most of the cases. Like I said, usually you can pick it up before having to go to the extreme of doing arthroscopy. The advantage of arthroscopy is once you say, yes, it is an ACL tear, you can go ahead and debride the cruciate, debride the meniscus at the same time as you're diagnosing. So that's the advantage of arthroscopy. Excuse me. Advanced imaging, we have a few owners that come in and just demand that they get an MRI to diagnose their ACL tear. I assume that's just because it's so popular in people that have meniscular ACL injuries, as they'll do an MRI or some type of advanced imaging. And I just think it's unnecessary in the majority of these cases. So usually you can talk them out of it when you come in and say, I just diagnosed ACL tear on the physical exam. I don't think we need an MRI, but it's there. As far as, if you guys need it, we have the CT and the MRI, but I think it's a rare case that needs it for an ACL tear. This is true of most things. That's good. Is Dr. Wong here? So on to some of the maybe more interesting things. Surgery is the treatment of choice for ACL tears. There's maybe a little bit of debate in some scenarios, but in general, it's going to be the treatment of choice. The only scenario where a dog has an ACL tear, and we're going to recommend medical therapy as the only treatment, there's kind of two scenarios I see. One is the dog is a high-risk anesthesia patient or high-risk surgery patient, as far as if it's immunocompromised or we're just going to get infection, something like that. Those would be scenarios where maybe we're talking about, let's do physical therapy, let's get an orthotic or a stifle brace, something like that for those dogs. The other scenario is owners that have financial constraints. They just can't afford to have surgery. And so we would recommend medical therapy in those cases. All the other cases, though, we're going to recommend surgery. And so this is, I don't know how popular this is, but the idea that in smaller dogs, specifically dogs less than 15 kilograms, there's a thought process out there that they don't need surgery. If you just wait on it, wait for that fibrosis to stabilize they don't need surgery. And the research that I did on this is all based on one study by this guy, Vassar, VetSurge 1984. And from that study, they concluded in the dogs less than 15 kilograms that over 80% of them improved. Where if dogs weighed more than 15 kilograms, I think it was 13% or something improved, so a much smaller percentage. If you actually look at this study, this is a terrible, terrible study. Not because it concluded that medical therapy is good, it's just there's no objective outcome assessments. It's all, how did the owner feel the dog did? We think it improved. What does that mean? Does the dog go from non-weight bearing to kind of touching it down? Is that considered an improvement? There's no force plate analysis. It's owner assessment. It's just not a great study. It doesn't mean it wasn't true. It just means that study is not a great way of going about proving that. But a lot of people still go off this study as far as for smaller dogs. And you may have seen that clinically. Certainly there's dogs that can do well without surgery. Their knee stabilizes. I've seen some bigger dogs that maybe don't need surgery because they got so much fibrosis going on. But just to kind of just group them all into they weigh less than 15 kilograms, they don't need surgery, I think is not correct. And we'll go through some of that as we get further into this presentation. So in general, the current recommendations, all dogs, all sizes, they need to be, at least the surgery needs to be discussed with the owners as far as a treatment. Does anybody disagree with that as far as the medical therapy? or any have different opinions on that for smaller dogs? We're not talking about cats here, just dogs. Or maybe we talk about it at the end, whatever you want. So medical therapy, I think, definitely has a role in treating cruciates. I think it's great when you do surgery and medical therapy together, kind of in conjunction. Surgery is for the biomechanical abnormalities that go along with the instability. That's where surgery comes in to correct that instability. But there's also a biologic factor. A lot of the papers you read to talk about organ failure, joint failure. You have all this arthritis. There's inflammation, cartilage damage. And you need to treat that as well, kind of this multimodal approach where you do surgery to stabilize the joint, but then medical therapy with the joint supplements, physical therapy, rehab, and then NSAIDs as needed to kind of completely treat these guys, kind of treat all aspects of the disease process.
You mentioned earlier having those braces for those folks that can't afford it.
Mm-hmm.
Is there a brand or a particular you like?
We've used Orthopets, Ace Ortho Solutions is another one. Ace Ortho Solutions. Those are kind of two that we've kind of ordered from. I'm sure there's plenty more.
And it's just called a stifle brace?
They have different ones. A lot of them are where you make a mold of the leg, under sedation, sending the mold in, send the measurements in, they'll fit it to the leg, the custom braces.
And how successful are they?
That's a great question. Those dogs,
those things aren't cheap.
yeah, the ones I've seen are maybe $500 to $700, something like that. Those dogs don't really come back and see us. They go, I guess the physical therapist, or back to you guys. Have anybody had experience with the braces? I really don't have a lot of experience with that, as far as follow-up. So back to surgery. Surgery is going to be the standard of care for cruciate tears in dogs. I think surgery is important, one, because it allows evaluation of the stifle. Not just looking at the cruciates, but also looking at the meniscus. I'm going to talk about that a lot more after the break. I think that's a huge part of ACL tears is checking for the meniscus. Make sure it's not torn, and if it is, you need to be able to deal with the meniscus because it can be, it can cause a persistent lameness after you, do the lateral suture TPLO. But for surgery for the ACL, there's kind of two philosophies out there that's dealing with the treatments. One is, let's just replace what's torn. Let's replace that ACL with a prosthetic ligament. And there are numerous options out there for you. You have the traditional kind of circumfibullar suture. You have all these new bone anchor techniques, tightrope, all that kind of stuff. We're going to just group all that into the lateral suture category. And we'll go through kind of each one of those. And then the other option is, instead of trying to replace the ligament, let's just change the biomechanics of the knee so they don't need an ACL. There's nothing to tear long term, and those are the tibial osteotomies. The two most popular ones would be TPLO and TTA, and we'll go into some detail of that as well. Ultimately, trying to figure out which one is best. Currently, it's going to be surgeon preference. So I know if you talk with Dr. Strupper, Dr. Calfier, or myself, we're going to do a TPLO or TTA. It's kind of which one we're comfortable with. Or we're going to do a lateral suture. It just depends on the dog, and we'll kind of hopefully get in some scenarios where we kind of figure out maybe where one's more appropriate than another for the individual dog. So you have all these options out there to treat ACL tears with. You've probably got 8 variations of the lateral suture. The TPLO, there's multiple variations. You want to use a locking plate. You want to use a compression plate. You can use a jig, not use the jig. TTA has multiple variations. There's other osteotomies out there. This kind of leads into my favorite quote of all time. It's called the law of the instrument. And it says, if your only tool is a hammer, then everything looks like a nail. I think that's very, very true. What it implies is that you have an over-reliance on a familiar instrument. Once you become aware of this, that you are just treating everything the same way every time, not looking at the little details, it's an ACL tear, I'm going to do a TPLO every time. Once you realize that you're doing this, you may realize that you've been trying to hammer in some of these nails that aren't really nails. Maybe they're screws. Maybe you should get a screwdriver and try to screw them in. It might work a little better than that hammer. And so this analogy, I think, works pretty good for cruciate tears. There's not one surgery that's recommended for every dog. Lateral sutures don't work in every case. TPLOs don't work in every case. TTAs don't work in every case. And you got to just figure out, these individual differences in the dog and try to figure out which treatments are most appropriate. Let's see. So for all of these surgeries, lateral suture, tibial osteotomies, it always starts with the Stifle Explorer. So the first thing you do, you're going to go in there and look, and one, just confirm that, yes, my physical exam is correct, the ACL is torn. You try to assess, is it a partial tear, complete tear, look at the amount of DJD that's there, and then also want to look at the meniscus. Like I said, we'll get into the meniscus evaluation after the break. What are some ways to do that? For the arthrotomy, I don't know how you guys do it. For the lateral suture, usually make a lateral skin incision. You can also make a lateral arthrotomy because you're right there on that side. I've also seen folks that flip the skin, you make a lateral skin incision and then flip the skin over and do a medial arthrotomy. Whatever you're comfortable with, in my opinion, whatever you're comfortable with, as long as you can see what you need to see and you can get to what you need to get to. If you have a meniscal tear, the most common place for meniscal tear is going to be that caudal pole of the medial meniscus. If you can get to that through a lateral arthrotomy, great. If you can't, then you need to go to the medial side and check it out. You can use a mini or a complete arthrotomy. Once again, if you can see everything you want to see through a mini arthrotomy, great. If you can't see it, then you need to extend it. You need to look. Make sure you look at the meniscus, look at the cruciates. If you just fly through an arthrotomy, say, yep, the ACL's torn, close it up, do a lateral suture, but you missed that meniscal tear, that dog's just not going to do well. Okay, so you need to pick up on that. For me, if I have difficulty, I do usually an arthrotomy from kind of the base of the patella tendon, right where the tibia starts, up to kind of the base of the patella itself. And if I can't visualize everything I need to see, I'll even take it a little further up the side of the patella where I can actually luxate the patella. As you can see in this view. I don't know if most of you guys do this or not, but if you luxate the patella, you can pretty much see everything in the joint. The medial and lateral compartment, you can get back to the caudal compartment where the caudal pole of the meniscus is. So I don't know if I need to orient you on this. This is kind of a craniocaudal view of the stifle. This is the trochlear groove of the femur. This is the cruciates coming here. This is going to be the lateral side because you have your long digital extensor here. And so the ACL comes from the lateral side to the medial side. This is going to be your tear right here. Does that make sense? All right. So first up on the different types of suture, or different types of surgery, is going to be the lateral suture. Once again, we're going to just group all of those surgeries where we're trying to replace the ACL into the lateral suture category. And one reason for doing that is there is not a study out there that compares the different ways to do a lateral suture. They're all just either presenting a new way to do a lateral suture, or they're comparing a lateral suture to a TPLO, or like a tightrope to a TPLO. There's no, the Fasttech is better than the tightrope or the old lateral sutures. Those studies just aren't out there. So I find it interesting. We're going to just group them all into one category. So the point of the lateral suture is to just try to mimic the normal cruciate. You want to find the points similar to where the normal cruciate attaches, origin and insertion, and just try to mimic that to limit that cranial drawer. There are numerous variations, and we're going to go through several of those as far as different types of suture, the different knotting techniques, attachment sites, the isometric points that everybody talks about. We'll go through that as well. If you have any questions or any advice for me, just let me know. So this is just a picture or a drawing of a dog that had just a basic lateral suture. Femurs coming here. This is the tibia. The fibula here, it's just the circumfibular suture. They've done a figure 8 pattern. You can also do a loop pattern, but they've just gone under the patella and then back through a bone tunnel in the tibia. This is kind of the classic lateral suture. One thing to go ahead, I just want to point out is where I've seen some folks make mistakes is they make this hole in the tibia, the bone tunnel, way too distal. It should be kind of a half a centimeter to a centimeter, depending on the size of the dog, caudal to the insertion of the patella tendon, so right at that little white line, that little bump. And then also the same distance kind of below the joint surface, so kind of up in here. I've seen it way down here, and if you can imagine how that suture would act, it's never going to stabilize that joint as far as limiting cranial drawer. So kind of go through some of the options. Prosthetic material, the classic one is using the monofilament nylon leader line. not fishing line, this is leader line. It's been shown to be much stronger, has less elongation. There's a couple of recent studies out on how to sterilize this stuff. The ethylene oxide sterilization is supposed to be much better than the steam sterilization. For the nylon leader line, has less elongation, more strength preservation. And then I would say in the past 10 years or so, this stuff's just kind of blown up. All these poly blends, this orthofiber, fiber tape, all this stuff with the new Arthrex lateral suture stuff has just really blown up. These things, or these materials are very strong. There's a ton of graphs you can see on all the little pamphlets of how much stronger this stuff is than the monofilament. It's supposed to elongate less. Of all of these, there's numerous different types. The fiber tape is supposed to be the strongest. It's what we use for the tightrope. So the whole idea that let's just find the strongest material that we can and use it for a lateral suture, that seems right. You know, you have dogs that stretch out the monofilament. You have dogs that have loose sutures. So it just seems, yes, let's get a stronger material and that won't stretch out. I mean, that makes some sense, but what it really does is just, it demands that you find those isometric points to place that suture. If you have a really strong suture and you place it poorly, meaning your anchor points are off, you're going to dramatically limit the range of motion of that dog's knee. So I think it puts a lot more, makes it more challenging when you use this type of stuff. The poly blends makes it more challenging to find that exact isometric point for that exact dog. They talk about, we'll get into the isometric points when we're talking about, you know, F1 versus F2, T2, T3, all these things. But I think it's variable between the breeds of dogs. You get some of these small toy breed dogs and their femurs like kicked over like this and they have these weird tibias. I think it makes it challenging. Also, we're talking about poly blends, you're talking about braided suture. There's a lot of folks I know that are afraid of braided suture, leaving it in the long term because they have increased infection rates. And there's an old study talking about using braided materials, braided non-absorbable materials there's a dramatic increase in draining tracts in these animals. You know, I think it was like 20% of the dogs had draining tracts with the braided materials. And when you have infections or draining tracts with this stuff, you have to take it out. When you take it out from a lateral suture, you know, a lot of these guys are still unstable afterwards. You need to put something, use something else, put something back in, or doing these tibial osteotomies. We see, I'll say a fair number of these guys where we take out a lateral suture and then do a TPLO on them, something like that once the infection is cleared. So it can be a big deal using this stuff. And this stuff's not the best thing ever. I've certainly seen dogs stretch out or break as well. But that's kind of the options that we have. So securing the suture, to me this is probably one of the most frustrating parts of the whole deal with the lateral suture is how are you going to secure it and how are you going to maintain the tension. Just realize the knot will always be the weakest part of your suture. It's because the suture's bent over on itself, these acute angles, you have all this shear force on it, but just in general, it's the weakest part of the whole deal. So you know, make sure you do as good a job as you can with it. Different types of knots. The square knot, the self-locking knot, where you kind of put a surgeon's throw and then kind of clamp it and then tie on top of it. That's actually been shown to be better than these half-hitch knots, where you kind of slide 2 half-hitch knots down. That's been shown to give a little more than some of the square knots. My personal preference is to do crimps. That's what I typically do. One, it's been shown to be stronger. There's less slippage with the materials. You can use it with the monofilament nylon. You can also use it with the poly blends. They make some. I know Securos makes some for the poly blends. But it's just been shown to be stronger. What I like about the crimps is that you can adjust the tension before you crimp it down. When you put the little clamps on the suture, you can put it to where you think it should be, and then you can put it through a range of motion and check the different drawers and the flexion and extension. If you don't like it, you can tighten it up and get it where you like it, and then crimp down on it and secure that tension. With throwing the knots, I've never been more frustrated with some of these things. You throw it down, it looks perfect, you got it perfect, you tighten it down, and then you put the dog in flexion or extension and he's just loose as a goose, and you're trying to like untie that knot that you just thought was perfect, or you have to just redo the whole thing. So to me, my personal preference is to use the crimps. So kind of move on with the bone anchors and all the new Arthrex stuff. There's been a focus on all these different isometric points, and so This is a picture of a stifle heading in this direction towards me. This is the femur coming down. The fibula lives here. And this is the tibia here. This is the long digital extensor. What they've done as far as the isometric points is just try to figure out which points are the best place to put your lateral suture, where your anchor points is. When we're talking about isometric points, you're looking for a point on the femur and a point on the tibia where during the range of motion of the stifle, the distance doesn't change between these 2 points. Okay, so realize for the classic circumfibular suture, you're placing it kind of F1 to F2, and you're coming down here to T3. All right, a lot of these newer procedures like the Fasttech, the tightrope, and all that, they're using kind of these T2, T3 points around the long digital extensor, and they're coming to the bottom of the fibula, this F2. A lot of folks say that F2, T3 is the most isometric points. That's what everybody's talking about. We're talking about isometric points. And we'll show a couple studies of that. Hulse and Rowe came out and said, of all these different points, these are biomechanical studies, they're not clinical studies. But the F2, so the bottom of the fibula, so this real caudal point right behind the long digital extensor tendon groove, that's the most isometric point in the dog. And that's what's recommended for the Fasttech suture from Arthroscopy and the new Swivel Lock and all that stuff. And then Fisher came out and had a study that questioned all of this. They did 12 different points on the femur and the tibia, and they did all these combinations. And their conclusion was the dog doesn't have isometric points between the femur and the tibia. With all of those points, when you flex that dog's stifle, the tension goes up, or the distance increases between those lines. So, that kind of makes sense. The stifle is not a true hinge joint. It doesn't just go back and forth. You have some sliding motion. There is some natural drawer there. That is normal. You also have internal rotation. We talk about the screw home technique, where as you flex and extend the stifle kind of internally rotates. So all that stuff adds into why it's so hard to find isometric points in the dog. And like I was saying before, when you're using those poly blends, you're using the ortho fiber and all that, you've got to find isometric points. That stuff's not going to give. Or if you use the monofilament and you're a little off, maybe got a little bit of stretch there. So you really can't talk about lateral sutures without talking about Arthroscopy. They have so many different systems out there. I think it's a pretty neat little company. When they came out with the Fasttech System and the tightrope several years ago, I was on board with that stuff. When I was a resident in Georgia, my resident Maine and I, we had the company come out, teach all the surgeons how to do these procedures. We wanted to do it on every dog. We were very excited. I remember doing my first Fasttech procedure. When I got done with the lateral suture, I dropped the dog's leg, and it actually dropped down where he actually touched his butt. He actually had a good range of motion. Usually when I do a lateral suture, you drop the leg and it kind of just still sticks up in the air. It doesn't have that normal range of motion. So I was very happy with using the anchors and using these different points. But then we started to see these guys back at kind of 4 to 8 weeks after surgery, seeing them for their rechecks. And it was so frustrating because all these dogs were lame again, or they had some increased laxity in that suture that was so perfect just a month ago or 2 months ago. So, overall, I think there's a lot of new things here, a lot of cool things, and it works great in some dogs, but not every dog. That's just my personal experience. So what we're going to do is just go through some of these Arthrex stuff, go through some of the newer techniques. Does anybody use any Arthrex stuff? Use the Fasttech tightrope? You guys know what I'm talking about? Anybody? Everybody just use the circumfibular suture? Okay. We'll just go through some of these just to present what's out there. So this is the Fasttech System from Arthrox. You'll get a little package like that, a screwdriver comes in a package. And what it has is just on the shaft, it has a screw, actually that's the bone anchor. Has a little line. That's how far you want to advance that screw in. It puts it right level with the joint. And then once you place it at the F2 position, so you're going to drive the little screw back up. This is a lateral stifle. This is a cranial caudal stifle. This is your bone anchor here, right below the fibula. You can see it here as well. You're going to place the bone anchor right at the F2 position. And once you get it solidly in there, you're going to unwrap the strands of your suture, which also run down the tube of the screwdriver. And then the bone anchor stays in the bone. You pull the screwdriver off, and you have your lateral suture already attached to your bone anchor. It's pretty slick. And then you make your little bone tunnel, which in this case what they've done is just driven one tibial tunnel and then attached it through a suture button and then ran it back up to the tibial tunnel and then tied it on the lateral side. That's called the Fasttech System, and that's something we use here. I used it as my main surgery for a couple years and just got a little frustrated with the amount of laxity I was seeing afterwards. So it's now my number 2 surgery. If my circumfibullar suture fails, I'll go with something like this. Or if you're in surgery and the fibula just doesn't seem like it's going to hold, you place that suture and it still seems pretty loose, then I'll go with this procedure to more solid bone anchor in the distal femur. This is a little bit better view of that Fasttech System. So we'll start on this side. This is the lateral view. You can see the bone anchors at the bottom of the fibula. You use the T3 isometric site, which is just caudal to that long digital extensor, that little prominence there. And then they've drilled through the tibia and place a little suture button here so you can just lap the suture over, then back up the same hole, and then tie it on the side. So that's the Fasttech System. And then you have the tightrope, which is, in my mind, kind of a variation of the Fasttech. The tightrope has been promoted as the lateral suture kind of for big dogs. And it's been around for a few years now. What it does is it uses bone tunnels through not just the tibia, but also through the femur, so your anchor points are stronger. For those bigger dogs, they're not going to pull out the bone anchor, the bone screw back here. The weight actually goes all the way through the femur, all the way through the tibia here. But the end result is you're left with the lateral suture. It's still just a lateral suture, just has bone tunnels, and then they use toggle pins or suture buttons on the femur and the tibia to secure it. There's been a couple studies out on this. The first 1,000 cases that were done, they basically compared the tightrope to a TPLO. The first 1,000 cases, they had 90% good outcome, 10% complication rate, which is very similar to the reports you're going to see on the tibial osteotomies like TPLO and TTA. Overall, I think it's very similar. The tightropes that I've seen is very similar to kind of the lateral sutures in the small breed dogs. Some of them do great. Some of them get loose. Some of them get infected. This is another picture of the drawing of the tightrope. Does anybody use a tightrope out there? Basically, you have your suture button on the femur, drill through the femur. You have your lateral suture here, and then another tibial tunnel here. But the end result is you just have a lateral suture. The newest thing from Arthrex, and I actually kind of like the idea of this one. This is the Swivel Lock. It's the same deal with the Fasttech in that you're placing the bone anchor right below the fibula on the back of the femur. You have your tibial tunnel as well. But when you get ready to tie it down, instead of using crimps or hand ties, it has a little place where you can pull the suture through kind of the bone anchor, and it's secured by kind of an interference screw in the femur. So you make a little mark. This is a pin making a little mark where you think the tension is going to be perfect. You screw it in, and then you can test the stifle and see, did you eliminate the drawer or not? And if you didn't, then you can unscrew it, pull a little bit tighter, screw it back in. So it gives you a little bit of fudge factor, I like to call it. And that's what I like with lateral suture, is be able to adjust it a little bit if it's not perfect the first time. The cool thing about this material here, it's called PEEK, P-E-E-K. It's this thermoplastic material that has vents in it, and the bone can actually grow into the anchor, so it should be even more secure with time. So talking about tensioning and how tight to make it, like I said, this is, in my mind, for lateral sutures, this is the most frustrating part of the whole deal. Ideally, when you tighten the suture, the stifle should be not in cranial drawer. So you have to actually, a lot of times, manually push the tibia caudally. You want to externally rotate the tibia a little bit. You want to make sure the tibias, or the stifle is about 100 degrees of flexion when you're tightening it down. There's a couple studies out there that shows just significant variability between surgeons, and even the same surgeon doing the same thing over and over again. You get just a variety of suture tensions when they're trying to do the same thing. I think that's interesting, and maybe that's why I have such an inconsistent kind of clinical outcome is I'm not putting the right suture tension on every time. That's possible. In general, I think there's a tendency to over-tighten. The idea that I'd rather be too tight than too loose kind of thing. And it's been shown in a study that if you over-tighten the lateral suture, it puts a significant amount of pressure on the lateral compartment of the stifle. It may actually make it worse long term. You're constraining that stifle. They may lead to degenerative changes down the road that are faster. So outcomes with a lateral suture. There's a lot of studies out there. There's a lot of great studies comparing it to other things. It's just presenting lateral sutures. Here's 200 cases of lateral suture. Here's the outcome. But in general, they do good to excellent. Definitely about 80% or maybe greater chance of having a good outcome. Main concerns of lateral suture is just long-term function. How long is it going to hold up? The idea of just having it hold up until the fibrosis sets in. That's kind of the thought process. A lot of studies, these dogs may not do great at first. The first couple of months, they may not have great function, but at a year, they seem to do well. So you may have kind of a longer term good outcome, or it takes longer for them to have a good outcome. So common mistakes that I've done myself or I've seen other folks do is when you're doing the circumfibullar suture, is that you just miss the fibula. You kind of place it back there, and then you miss you want to get it in the ligament between the fibula and the femur. And sometimes you just miss that, and it just tears through that lateral head of the gastroc, which is the muscle attachment right here. If you're using bone anchors, I've seen folks put the bone anchor instead of right here behind the fibula, place it way too cranial. And the reason for that is it's really hard to put a bone anchor back there. You got to get way back there to do it, to get that angle. So I've seen them place it way too far cranial. The most common scenario, and this is why I put this X-ray up here, is instead of having your tibial tunnel way up here, see how low that is. That's just not going to be an isometric point for the dog stifle. That's just not going to work long term as far as your suture stabilizing the knee. And then this is probably less than 1% complications reported in all studies that I've seen, but you can definitely catch the tibial nerve when you do a lateral suture. The tibial nerve lives under that biceps fascia, so when you reflect that fascia back, and then you have the calf kind of sitting there in the fibula, you want to look down there, look in that groove, see how far away that tibial nerve is. Make sure you don't grab it with your suture. All right, we're going to move on to the other treatment options other than the lateral suture. We'll get into what's called the tibial osteotomies. I personally think this is the cool stuff. This may be very boring for you, but this is what we do on a daily basis. We'll talk about tibial osteotomies, TPLOs, TTAs. We're no longer talking about that, trying to replace the ligament. We're just trying to stabilize the knee by changing the biomechanics of it. So the important thing to know is what are the biomechanics before you do these procedures. And the idea here is that it's more than just the bone structures. You have the femur, you have the tibia. The green line here represents the plateau of that tibia, which is important, but also how the muscles attach and pull on the tibia and the femur. You have the patella ligament here that attaches to the front of the tibia. It's attached to the quadriceps mechanism, so as they stand on the leg, the tibia is pulled in this direction and actually pulled a little bit forward and then up. You have the gastroc that pulls this way on the femur. You have the hamstrings which pull the tibia. Just all this stuff combined gets very confusing, but it's very important to help understand how these TPLOs, how the TTAs work. So this is kind of the classic picture. It looks like it's from the early 1990s of explaining how a TPLO works. And I think it's pretty basic and it's pretty easy to understand. In this picture, the slope here, the heel this is on, this is the tibia and this is the tibial plateau. So most dogs have an angle of about 25 to 30 degrees. So the slope's 25 to 30 degrees. The wagon here is the femur. And the femur in a dog, when they stand, they kind of have that semi-crouched position. They're kind of sitting on that angle, and it wants to go downhill. It's prevented from going downhill by this rope. The rope is the ACL. It's the one thing in the joint limiting or preventing that wagon from going down the hill, from preventing that femur from sliding back on the stifle. So the TPLO, the end result is that we're taking this heel away. You're going to level off that plateau and make it level. So now there's no force to push that wagon backwards. So there's no need for an ACL. And that's kind of the general overview of TPLO. I think it explains it pretty well. We'll get into a little bit more complicated stuff. So taking X-rays of the tibia, I think, is very important, or of the stifle beforehand is very important, and things to look for. One of them is being able to look at the tibial plateau, just taking some X-rays and looking and saying, does that look like a normal proximal tibia? Or does it have some crazy slope? So instead of being right here, does it have this crazy slope going this way? That's important to know. That's not, if you have a slope that is really steep, that's not a dog you want to be doing a lateral suture on. That's just never going to work, right? The forces on that lateral suture are just going to break down. So I thought I'd just kind of go through how we look at X-rays, how we kind of evaluate the plateau. Not that you have to make the measurements. This dog has a 27-degree slope, but just get an idea of what is a normal-looking proximal tibia, okay? So the plateau, the proximal tibia, this is the weight-bearing surface. When the femur comes down and contacts the tibia, it doesn't contact the whole top of the tibia. It's just this back half that has a slope on it. These marks here, the A and the B, that's where the cranial cruciate ligament inserts. That's where the caudal cruciate ligament inserts. And that's kind of the cranial and the caudal aspects of the plateau. These little bumps here, these are the intercondylar eminences. What does that mean? When you look at a cranial caudal X-ray, you look at the stifle, this is the femur here, this is the tibia, you get these two little bumps. These are the intercondylar eminences. When you take a lateral X-ray, they kind of superimpose on themselves here. That is the center of the joint. So when we're measuring, where's the center of rotation for these TPLOs, we go right at the eminence here. Let's see. And so here's a lateral X-ray of a stifle showing the proximal tibia. And so we're just going to find these landmarks on this dog. Looks like the cranial aspect's going to be about right here, and the caudal one's going to be somewhere in here. You can see the intercondylar eminence right here. Sorry, that's kind of blurry. I'm just going to label them for you, make it easy. And so to just take that a step further, this is the same X-ray we just looked at, had the two dots. We just connected those two dots and made a line. That's the tibial plateau angle. And this is how we would measure it on a lateral X-ray. We would take an X-ray of the entire tibia. It doesn't matter what angle the stifle's at. We're just looking at the actual bone, the tibia. And so we have the top here. We've made a line with our tibial plateau. The intercondylar eminence, this red arrow here, that's the center of that joint. The stifle, we want to find the center of the tarsus, which is going to be the center of this circle here we kind of made where the talus is. And we're just going to connect those two lines, the center of the stifle to the center of the tarsus. And that's our line. That's the mechanical axis of that bone. When a dog bears weight on the tibia, all the force goes down this line. And then we're going to draw a line, this dashed line, that's perpendicular to the mechanical axis. So it's just a right angle between the two red lines. And then we're going to compare that dashed line to the angle of the tibia, and that gives you this tibial plateau angle. And most dogs, it's between 23 and 28 degrees. I tend to get the dogs that are a little higher for some reason. They're kind of low 30s. But the range has been shown to be between 12 degrees and up to almost 60 degrees. So you have quite the range. And it's important to know, in my opinion, it's important to be able to at least look at it and say, that looks pretty normal. Or it's got this enormous slope here. And that, like I said, may change the treatment that you want to do. Anything over 34 degrees is considered excessive. And we have a little bit longer talk with the owner about maybe this TPLO isn't going to rotate it all the way level. Maybe we need to do a couple, a different procedure with the TPLO. And I'll get to that at kind of the end of this talk. So that's how we measure, so we're going to walk into a TPLO. It has a pre-op angle of 27 degrees. We're going to try to level it off flat. So it just gives us a measurement. I'm going to go a little bit more into the biomechanics of how the TPLO works. So this is just a drawing of the stifle facing in that direction. And we're just, if you're talking about the plateau, it's going to be hidden under the meniscus, but it's going to be kind of basically in this direction. And what we're going to do is set up a coordinate system. This is right out of math class or physics class, whatever you prefer. But we're going to set up the coordinate system right on the center of that joint, right on the intercondylar eminence. That's where this line's going through. It's just a right angle. And then we're going to put in our mechanical axis. That's that line we drew before. The center of the stifle to the center of the tarsus. We're going to draw that line through it. And then we're going to get into the weight-bearing force. So when the dog stands on the stifle, this is the force of the dog standing, this blue line. Notice that that force is not perpendicular to this line here, not to the plateau. And to me, this is the whole thing. If it was perpendicular to the slope, I'll tell owners, if it's flat surface to flat surface when they're bearing weight, you can push on it all day and it's stable, right? But it has an angle to it. It's kind of kicked back. As you push harder, it's going to slide by. It's going to slide down that angle, kind of get that shear force. And that's what's happening in the normal dog knee. You get a shear force. And we'll go through that as we get further in here. So when you have this blue line and you compare it to our coordinate system, there is a Y component, which is this green arrow, and that's opposed, that is perpendicular to the plateau. So that's basically just, that weight's taken by the bone. You don't have to worry about that. But there's also this X component, and that's the force that's unaccounted for by the bone. So that's where the cranial cruciate ligament comes in and takes all that weight. So when you have a cruciate rupture, there's nothing supporting that, and that's when you get this drawer motion when they stand there. That's when they're standing there and their knee is in cranial drawer, or when you take, you feel the knee and put it in weight bearing, it's unstable. So here is something a little bit more simple to look at, hopefully. As you have a dog before we do the TPLO cut, you can see this angle is here. And then afterwards, when we make the TPLO cut, we're going to just rotate that proximal tibia until the top of it is now flat when you compare it to the long axis of the bone. So I'm just going to draw those forces back in, try to make it a little bit more confusing. But before surgery, you can see that the forces don't line up with the bone structure. You have this force that's unaccounted for. It's usually supported by the ACL, but once it tears, then you have an unstable knee. So with the TPLO, we just rotate that plateau so now it's perpendicular. When they stand on it, now they're standing on a flat surface, and it holds the weight. And for those of you that haven't seen a TPLO, once you make that cut and rotate it just like you want it, you have to support it. And we usually put a metal plate, usually made for that surgery, usually 3 screws above, 3 screws below, until the bone heals. So that's the TPLO. How do these dogs do, or what happens after you do a TPLO? It's been shown that cranial thrust, that when you put them in weight bearing, is eliminated when you rotate them, not necessarily to 0 degrees, but been shown around 6 degrees is actually what we're shooting for. And when you do that, it converts that cranial force, that force that's pushing that tibia forward, it actually starts pushing it backwards, anything past that. So that puts a little bit of strain on the caudal cruciate ligament. So a reason not to do a TPLO would be a dog that has a caudal cruciate tear in addition to a cranial cruciate. That's pretty rare, but that'd be something to know. Complication rates with TPLOs. There's a study by Fitzpatrick. This guy does all kinds of research studies. He did 1,000 consecutive dogs that had a TPLO, and he came up with a complication rate of 15%. The most common complication would be infection, and it was at 7%. Other things that can happen with a TPLO, just like with the lateral suture in the TTA, you can have meniscal tears. The implants can break. You can break the tibial tuberosity. You can break the fibula. And the tibia can break. All these things can happen. I would say as far as implant failure and things breaking that are significant, you're talking less than 1% chance. All right, so pretty low. Unfortunately, we do enough of these surgeries where we see that less than 1% chance. I've seen 2 dogs break screws and kind of break the top of their tibia. When you get in that scenario, when they have a catastrophe like that, you're no longer trying to get that tibial plateau perfectly level. You're just trying to give them a functional leg. So that would be the downside of some of these tibial osteotomies, is that there is a chance if you had a catastrophe that it's going to be tough to salvage. But once again, in all the reports that are out there, there's less than 1% chance of that happening. Okay, and I would say if you stick with the techniques, the recommendations, which is what we try to do, the chance is probably been less than that. So that was the TPLO. If anybody has any questions about the TPLO, I would love to sit around later and talk about it. I feel like I talk forever on the TPLO. So now onto the TTA, the tibial tuberosity advancement. It is also a surgery that relies on the dynamic stability of the joint. It relies on the muscle forces to stabilize the knee. And so I'm going to do my best here to kind of go through how this works. And it's going to be a little bit more brief than the TPLO. But the idea is it focuses on the force through the patella tendon. This is the stifle. This is the femur, the patella. This is the tibia. We're facing in that direction. And the patella tendon attaches from the patella down the tibial tuberosity here. And as the quadriceps muscle contracts, it pulls in that direction, pulls along this green line. And so once again, if you look at the tibia and the plateau, this is the tibial plateau line. And you want all forces, for a knee to be stable, we want all the forces to be perpendicular to this line. So I drew in this other red line that is perpendicular to the plateau. Notice the green line of the patella tendon is not perpendicular. So there's going to be a shear force. So instead of two things pulling against each other, there's going to be an angle. So as you pull against it, it's going to want to slide forward. This force pushes the tibia forward. Okay, so the whole idea of the TTA is to try to neutralize that shear force. And so we're going to make this green line line up with the red line. So this is a drawing, hopefully going to help show that. So this is before surgery. I have the femur, the tibia here. There's this red line or pink line coming up the patella tendon. This pink line is perpendicular to that line. It's just kind of basically moving this force over to the center of the joint. And what it's showing is that this pink line is not perpendicular to the plateau. This yellow line is perpendicular to the plateau. So what we want to do is just kind of shift that pink line to make it look like the yellow line. And how we do that for the TTA is just cut off the tibial tuberosity and then advance it forward. And so now that pull of the quadriceps muscle to the patella tendon is now going to be perpendicular to the tibial plateau. That kind of makes sense? You basically just advance it forward. And so this is what the TTA looks like when you get done with it. You've advanced it forward. There's a little cage that fits in between the tibial tuberosity and the rest of the tibia. There's this plate that goes along with it. It's essentially a tension band. The force you're trying to oppose with the TTA is the pull of the quadriceps, just like you are with like a patella luxation when you're doing a tibial tuberosity transposition. Is the force on this tibial tuberosity is in that direction, so you want to hold it down, and that's what this plate essentially does. It's a tension band. There are numerous variations of the TTA, as I'm sure Dr. Stripper will tell you, as far as using, not using this plate, different types of cages, all that kind of stuff. But the idea is you're just advancing it forward to stabilize the knee. How do they do with the TTA? Most dogs do very well, just like the TPLO. There has not been a study that's shown a difference between the TPLO and the TTA. One thing to note is in the studies, if you do sort through them, there has been a little higher complication rate associated with the TTA. And what has been noticed in some of these studies is that they may have a higher meniscal tear from a lot of these studies are, like the, I guess these are 2012, 2013. A lot of the studies are a little older, kind of early 2000s when this procedure just kind of came out, and they're having a lot of meniscal tears. I think a lot of folks now do meniscal releases to prevent meniscal tears after, and that keeps the complication rate down. But that's the TTA. And so these are in my mind, these are two completely different ways of going about stabilizing the knee. It just kind of blows my mind that, the TPLO, you're thinking about certain forces. The TTA, completely different idea of using the patella tendon, but they both do the same thing. They both stabilize the knee. They're kind of just two completely different ways of going about doing it. What I like about these procedures is that it's a ligament injury. When I think about ligament injuries anywhere in the body, is that when you're trying to repair it, there's a chance it could, sometime in the future, it could tear again. Something can happen. You can strain it. If you're trying to repair a partial, tear, it may may tear again or strain again. What we're doing with the tibial osteotomies is we're just changing the bone structure to stabilize the knee. Bone has the ability to heal back to 100% normal strength. So you just wait the 2 months for this bone to heal, and then this is just the new shape of the tibia, and it's going to be as strong as it ever was. There's no ACL to worry about tearing again, or no ligament to worry about tearing again. To me, that's the beauty of these surgeries. That's pretty much just the same kind of slide there. So there's a ton of stuff out there as far as ACL tears in dogs and all the research. The majority of them are biomechanical studies where they're using cadaver dogs or looking at all these different isometric points, or they're using all these different procedures and just trying to test it on these cadavers. there's not that many clinical studies out there, and the ones that are out there, a lot of them are not great. I find it interesting that some of them got published, having gone through the process. But there are a few studies out this year, 2013. Some of them are pretty good, and so I thought I'd kind of go through them and just show you what's the new evidence out this year. The first study is by Gordon Evans, came out in JAMA earlier this year. This is the first of, this ACL stuff's been around forever. This is the first prospective, randomized, blinded clinical trial dealing with ACL stuff that's out there, and it showed a significant difference between the TPLO and the lateral suture. In this study, they used pressure platform gait analysis. They used a pain score. They asked owners, how they thought they were doing, thigh circumference, stifle range of motion. They had some objective and some subjective outcome measures. They followed them out for a year, looking at dogs that had TPLO and lateral suture. These are all dogs that just had one side that was torn. Overall, both groups improved, which is what we'd expect. But the TPLO group, using the force plate analysis, they did significantly better at both a walk and a trot. So this is the first study that's been out there that shows, hey, the TPLO, those dogs actually do better over a year after surgery. So that's huge. Owner satisfaction. I think the study is pretty cool in that the owners were blinded to what procedure was done. So they didn't know if their dog had a TPLO or a lateral suture, which I think is a pretty neat thing, and definitely would be, helps the study as far as its methodology. But the TPLO, the owners were satisfied in 93% of the cases, and the lateral suture 75% of the cases. They're both pretty good, but I think these numbers kind of line up with what we see clinically here. As far as dogs that have the osteotomies, I think it's about 90% satisfaction. Maybe 9 out of 10 dogs do really well. In the lateral suture, we'll probably see 1 out of 4 kind of not do so well. Might need to have it redone, something like that. In my mind, of all the studies that are out there, this is about as good as it gets for a veterinary study with ACL tears. This is the best study I've seen. So that's out there this year, and it actually shows, historically there's a lot of papers saying no study has shown that anything is better than the rest, and everybody kind of defaults to that mindset. Well, nobody's shown anything. Well, this study shows it. The TPLOs, those dogs do better. There's another study out this year by Sam Nelson. It's a prospective clinical trial. They compared lateral suture to TPLOs, and they compared it to a control group, normal dogs that didn't have ACL tears. And the whole point of this was to kind of see how fast they recovered a full weight bearing of that leg at both a walk and a trot, and they used a force plate analysis to do that. They showed in this study that dogs that had a TPLO regained normal function faster, and that was significant compared to the lateral suture. Also noticed that at about a year out from surgery that the TPLO dogs are actually using that leg very similar to the control population, the dogs that didn't have ACL tears. This study is not quite as good as the other one, but it's pretty good. It's a prospective study. They use force plate analysis. They have a control group. Pretty good study. Another study out in JAMA. This looks specifically at overweight dogs with ACL tears. And what they did was compare dogs that had a TPLO plus medical management, like physical therapy, pain medications, joint supplements, and they compared it to a group of dogs that didn't have surgery. They just got medical therapy. They got physical therapy, the medications, they just didn't have surgery. This was a prospective study. It was randomized. It was a clinical trial, and it showed the dogs that had surgery did better. Surgery plus medical therapy had better outcomes. One thing to note is at half a year, 6 months in, for the TPLOs, about 90% of the dogs had what's considered a successful outcome. They're using that leg great. Where only about a third of the dogs with the lateral suture, not the lateral suture, for the medical therapy. Let me back up. For TPLO, 90% of the dogs were doing well at 6 months. And then for the medical therapy group, only about a third of them are doing well. So at 6 months, it's very clear the dogs that had surgery were doing well. At a year, so 52 weeks out, the TPLO had a little bit lower at 75% success rate, and the medical therapy was up to about 65%. So the difference between the two at a year was not that convincing, all right, between medical therapy and tibial osteotomies. So in my mind, there's kind of two ways to see those numbers. One is to say, well, why do we need to do a TPLO if a year they're going to be doing just as well? And my mind is, I don't want to deal with that owner for a year while they're saying my dog's not doing well. I think waiting a year for your dog to do well is unacceptable. So doing these surgeries helps get there faster. That's my opinion on that. And then I heard that. I heard that. So then this last study, this is a study that compared the tightrope, so the lateral suture from Arthrex, the TPLO, and the TTA, and they had a 1-year outcome. And what they did is basically just had subjective assessments. They had the owner, they had the vet just kind of say, were they doing well, were they not doing well, give them a grade layman's just watching them walk. There was no force plate analysis. They didn't do any objective outcome measures or results. This showed that the TPLO and the tightrope were superior to the TTA because the TTA had more complications and the dogs were more painful subjectively per the owner and per the vet. And that was the conclusion of the study. I would say, if you look at, this is what's out there. This is not a great study. This is a new study out this year, but it's something that you would see in veterinary medicine 15 years ago. There is no force plate analysis. There's no objective analysis. This is not a good study, but it's about the tightrope. It's pretty cool. Everybody likes it. It's just not a good study. The other thing to note is that one of the authors of the study invented the tightrope. All right, he gets a paycheck every time somebody does a tightrope. So I think that's just interesting that they would allow someone to publish the study. The person actually invented, the procedure. So that's out there this year. I think it's a terrible study. I can't believe it got published. All right. Enough of that. So post-op management for our guys that have surgery here, lateral suture versus the TPLO, TTA, the recovery is the same. They're all going to have an e-collar for 2 weeks. They're all going to be restricted as far as activity for about 10 weeks. We're going to do passive range of motion. They're all going to be on leash walks for 10 weeks. They'll get pain meds usually for the first 2 weeks and then joint supplements for the rest of their life. That's the classic kind of ACL recovery. I personally think that physical therapy, like getting a physical therapist involved, is great. A couple studies have shown those dogs do better. We're trying to get a program here where a lot of our post-op cases see the physical therapist and maybe go and do some underwater treadmill stuff like that. I think that's the future of orthopedic surgery in dogs, getting the physical therapist involved. So overall, I just want to make sure it's clear. It's not just doing the surgery and the dog's going to do great. A lot of them do well, but I think you can make them do better if you treat the biologic part of the disease as well. Joint supplements, pain meds, do the physical therapy part of it as well. So one thing the owners must know, you need to tell them, is that a lot of dogs will tear the other side, the other ACL. It's been shown that in less than a year, dogs that tear their ACL, about 37% will tear the other side within a year. So Labradors, about half of them are going to tear it within less than 6 months. All right. So we'll see a lot of those guys back. Why does it happen? Most people think it makes sense that if they're holding one leg up, they put a lot of pressure on the other leg and it kind of wears out faster. And that may be true. The other idea is they've got this chronic degenerative process that's happening in one knee. It's probably happening in the other as well, just maybe not as advanced. But it's definitely going to happen. And it's best, in my opinion, if you have already talked to them about this before they tear the other side. They're kind of expecting it. We've had a couple of dogs that I've seen a dog walking out to the owner the next day after surgery. You can see him holding this leg up, and all of a sudden they drop down and they start holding that other leg up and just walk them right back in. The recovery is we expect them to be doing very well by about 2 or 3 months after surgery, kind of getting back. What I tell owners is we call it near normal function, where your neighbor is not going to know that your dog had surgery long term. If you watch your dog pretty close, you might know they might be a little lame after some hard exercise, but generally they're going to do very well. That's the goal with these surgeries, is to get them back to pretty much normal function. So what happens if these dogs don't do well after surgery, kind of suboptimal recovery? The top 2 reasons that would happen in my mind would be infection, and that can be right after surgery. They get an incisional infection because they've been licking that incision, or there's some contamination at surgery, or an infection down the road. 4 weeks out, 6 weeks out, they start to become lame. They may have an infection associated with the implants in there that may not be obvious right after surgery. But that's one of the top rule outs. And then the other would be a meniscal tear. Meniscal tears have been reported in dogs after surgery, after stabilization surgery, between kind of 2 to 5% chance of that happening. I personally think it's a little bit higher. One of the reasons it happens is that you miss the meniscal tear at the original surgery. You miss maybe a little teeny tear and it just progresses and now it's a full-blown tear. Or some of these guys, the stability is not there. You don't stabilize the knee quite as well. There's still some drawer, and then they tear their meniscus after surgery. Implant failure, like I was saying before, with the tibial osteotomies, you're talking about breaking screws, breaking plates. That's pretty rare, probably less than 1% chance. For the lateral suture, I think it's about 1 in 5, something like that. Maybe 1 in 6 will have to have that redone, not necessarily because it broke, but maybe because it's too loose. It's not really doing what it's supposed to do. And then once all these have been ruled out as possible causes for their suboptimal recovery, then potentially we can chalk it up to maybe it's progression of arthritis, and then you can treat them medically. In my mind, you need to kind of go through this rule-out list before you just say, they didn't do well. So we'll talk really quickly about the meniscus. It's been shown that over a third of dogs that come in for cruciate tears, they'll have a meniscal tear at surgery. And I'll say that in my mind, I think I see about 1 in 4. That means I'm missing some tears. So if you're not seeing this percentage of meniscal tears when you're doing ACL tears, then probably because you're missing them. You're not looking hard enough. You're not probing enough. And so that's what I want to just get that point across, is if you're going to do an ACL surgery, you have got to assess the meniscus and then deal with what you see. Only about 30% of dogs are going to have a click. So if that's what you're going off of to tell if they have a meniscal tear, you're missing about 2/3 of the dogs that have meniscal tears. They're not all going to have clicks. Just some helpful tools as far as looking at the meniscus. We use the Homan retractor here. I think it works great. Does anybody have a Homan retractor? Anybody use that? It's a little instrument that has a little beak or nose on the end, and you stick it through the stifle and you grab the caudal aspect of the tibia and you help to lever that tibia forward. You force it into cranial drawer. It kind of presents that caudal half of the stifle to you so you can assess that meniscus better. I think it's a very valuable tool for assessing the meniscus. If you don't have an assistant in there with you, you can use a stifle retractor. You kind of catch the pins up in where the origin of the caudal cruciate and the insertion of the cranial cruciate, and it kind of distracts the femur and the tibia and lets you look in the back of the stifle. Dr. Calfee's a huge fan of this. But the whole idea is you need to look back there. You need to see. If you're not looking back there, you're missing meniscal tears, and it may be a reason why some of your dogs aren't doing as well. Another thing that's been shown is not just look at the meniscus. When I talk about the meniscus, I'm talking about that caudal pole, the medial meniscus. So on the inside of the knee, at the back. That's what we're looking for. We're trying to assess how that meniscus looks. And sometimes it's very obvious the meniscus is foot forward, but sometimes it's not. It's been shown if you probe the meniscus, sometimes we'll use a depth gauge, you can use a little nerve hook, but just to kind of probe it and see if the little hook catches on anything. So in this example, this is cranially here and this is caudally. This is the medial meniscus. If you're not probing that meniscus, you're going to miss that tear. And that dog may have a lameness that pops up a couple weeks, couple months after surgery, and it's going to be because of this. The bucket handle tear, of all the tears that have been seen in dogs, about 75% of them are going to be bucket handle tears. I think it's just because they're so obvious when you go in there. What we're talking about, if you look at the kind of cross section of the stifle, this is cranial again, this is caudal, this is medial, this is that caudal pole of the medial meniscus. Part or all of that caudal pole gets flipped forward in kind of a bucket handle appearance. What you see at surgery is this. This is going to be a craniocaudal view of the stifle. This is the trochlear groove right here, kind of going, the patella will be right in here. This is the bottom of the femur. This is the long digital extensor. This is the kind of the cranial proximal aspect of the tibia. And then you have this big white thing sitting right there. It's kind of just wedged up in there. That is a bucket handle tear of the caudal pole of the medial meniscus. That's what you're looking for. If you see that, we need to remove that piece of meniscus. And the way I describe it is it's kind of taking the pebble out of your shoe. If you're walking with a rock in your shoe, when you take that out, it should feel a whole lot more comfortable. And as far as taking it out, as we're talking about meniscectomies, what you're talking about doing is taking off that caudal pole of the meniscus, not the whole meniscus, not the whole medial meniscus, but just the part that's torn. And so there's two attachments for that caudal pole. Way back here on the axial portion, kind of near where that caudal cruciate is, and then medially right next to that medial collateral ligament. So you just need to be careful you're not cutting those other ligaments. You're not just kind of just jabbing back in there. You want to actually visualize what you're doing or what you're cutting before you do it. And then realize everything underneath and above is going to be just all cartilage. So just be aware of that. You don't want to be just cutting in, sticking a blade back there and cutting other ligaments, cutting cartilage. Just be careful. What I typically do is try to grab that meniscus with a probe with a nerve hook and kind of hang on to it, or I'll use a real small hemostat, like a little small ostrich, got some teeth on it, and just get a hold of it. And then I'll pull it one way, cut it, pull the other way, cut it, and then you're done. In small breed dogs, these really small stifles, I think it can be very frustrating. But the key is, in my mind, stick with it. You definitely want to get that meniscal tear out if you want that dog to do well. It's also been described you can do a caudomedial approach. So instead of coming in the front here, you can come around the back behind the medial collateral and you'll be right on that meniscus. And that might be, in some cases, a little easier place to get to it. For dogs that have meniscal tears, after surgery and you go back and you remove that meniscal tear, it's been shown that over 90% of those dogs are going to improve as far as their lameness. So it's important to diagnose that after surgery and to go and talk to veterans how important it is to go back in and actually repair that meniscus or take out the piece that's torn. They can really do well after it. The meniscal release, that when I was coming through my residency, we released all the dogs. We did TPLOs, TTAs on. We would just to prevent a future meniscal tear. The idea was people aren't going to come back for another surgery. We got one shot at it. Let's release the meniscus by just cutting it here or here and allowing that caudal pole to kind of move with the femur so it won't tear in the future. That's fallen out of favor. There's been some recent studies that show if you cut the meniscus to release it, you take away all the biomechanical properties of that meniscus. It's basically like not having a meniscus back there. And so it's kind of fallen out of favor. Unless you are concerned that there's a problem with the meniscus, the meniscal release is kind of fallen out of favor. So we've kind of stopped doing that. So we're almost done, I promise. Concurrent abnormalities with ACL tears, patella luxations, I think is very important to pick that up on the pre-op exam. If you're just filling for a drawer and you miss that patella luxation, that's something that after surgery you're going to be dealing with. We try to correct both the patella luxation and the ACL at the same surgery. That's the goal. So for small dogs, what are your options with medial patella luxation and ACLs? You can do what's called an anti-rotational suture. That's also known as a lateral suture. So as you do the lateral suture and you tighten it up, you're externally rotating that tibia. That pulls the tibial tuberosity laterally. And that should help realign the patella in the groove and hopefully correct not just the ACL but also the patella luxation. The key there is it makes it very easy to tell when your lateral suture's failed because the kneecap will start luxing again. You'll get that internal torsion. But that's an option. Another option is to do a tibial tuberosity transposition where you're cutting off the tibial tuberosity and then you're also doing a lateral suture with one of these new Arthrex, doing the Fasttech or the tightrope where the anchor point for the tibia is further caudal than the tibial crest. So you can kind of avoid the tibial tuberosity by drilling a little further back on those anchor points. For large dogs, in my mind, large dogs that have ACLs and NPLs together is a nightmare, or it can be a nightmare. I have one I'm doing next week. It's like a 100-pound dog. I'm already scared of it. So what do you do? It depends on what's wrong, what's causing the patella luxation. All these guys will have tibial torsion, or they're just real bow-legged. Their tibia is kind of turned in. And so when we do the TPLO, we can bend the jig pins to kind of torque them back out, kind of straighten it that way. And that's a pretty common way to correct the abnormality. Other dogs, you can do, just like we do the lateral suture, you can do a tibial tuberosity transposition and then also do a TPLO. That's, in my mind, one too many pieces of bone up there. It can move around. There's not a lot of studies out on that, but in my mind, it increases the risk of having a complication. I prefer to make just one cut and deal with it. And that's where the TTA kind of comes in. I think this is an advantage of the TTA, is you're already cutting that tibial tuberosity, you're advancing it forward. You can also move it further laterally, advance it forward and laterally, and hopefully correct the ACL and the patella luxation. So that would be an advantage of a TTA. The bigger dogs with patella luxations, how I typically work them up is not just take x-rays of the stifle, but I take x-rays of the femur and the tibia. I want to see what is curved and what is straight. A lot of the dogs will have this big curve, the big varus to their femur. And it's important to know that before you walk into surgery. What is the abnormality? If they have a big old curve here, big old varus, then it's worth coming in, taking out a wedge of bone and straightening it at the same time you're doing your ACL repair. It's a big surgery, but there's nothing more frustrating than doing a huge surgery where you're doing a TPLO, trying to correct for the patella luxation, and the dog comes in at 2 weeks, the kneecap's already popped back out. You want to try to correct it all at once at surgery. And then lastly, talking about the tibial plateau, does the slope matter? Does it matter how steep the slope is? I would say this guy would say yes. So we'll kind of go through. Anything over 34 degrees is considered excessive. On the left, this would be a pretty normal tibia, 24 degrees. This is not. This dog has a 47-degree slope. In my mind, you want to be picking that up on your initial X-rays. Does it seem pretty normal? Does it seem really awkward? What you can see on this guy is not just the slope's abnormal, but you can see how his tibia kind of kicks back. He's got an angular limb deformity. That's why he has that steep slope. So that's going to change how you may approach that case. Real quickly, what that means is usually you're doing a TPLO to rotate it as far as you can. Realize you can't take a TPLO and just rotate him 50 degrees. You can only rotate him usually for a correction about 25, 30 degrees, something like that. And then you come in and make another cut called a cranial closing wedge osteotomy to correct for the rest of the rotation. So you're rotating the TPLO as far as you can, and then you're taking a wedge out to rotate it even further. And the end result, if you kind of ignore all this metal here, is that the top is now flat. This is a complicated surgery. This is not fun, but they can do really well with this. And the key is just picking up on this beforehand. You don't want to walk into surgery and go, let me see the X-ray, and you're in surgery and you go, oh my gosh, this thing has a huge slope. You want to know that beforehand so you can talk to the owners and maybe definitely refer those cases. Doing the double cut increases the complication rate of reoperation to around 20-30%. So a lot of these dogs are going to be going back to surgery for breaking some implants, things like that. It's very important that the owner knows that beforehand, so you've already assessed it. And seen them with pre-op rads, you can kind of guide them through the process. So this is a dog I did at Georgia. We've done one, maybe two here since I've been here. This dog has a pre-op slope of 46 degrees. We did a double cut. We did a TPLO, and then we also took out a wedge of bone, and the end result was about 3%, or 3 degrees. So that was a long surgery. It was not fun, but that dog did really well. It just takes some pre-op planning. So overall, cruciate surgery, the take-home points here. Surgery is the treatment of choice. We're not going to recommend medical therapy unless there's reasons to not go under anesthesia or reasons to not do surgery. Partial tears are just as important as complete tears. And being able to diagnose that partial tear, I think, is sometimes difficult, but it's important that you pursue it. Okay, those dogs can do really well. The sooner you catch the ACL, the better. As soon as you figure out it's an ACL tear, send them for surgery. Try to slow down that progression of the arthritis that's there. Always take pre-op radiographs. 2 view radiographs is a stifle. If the owners don't want you to do it, just include it in the surgery fee. You're going to get in some trouble if you're not doing pre-op radiographs. It's going to help you. Evaluate the meniscus. If you're going to do surgery on the ACL, you've got to evaluate the meniscus. And then third, you want to pick up on concurrent abnormalities like really steep slopes, patellar luxations, things like that. Most dogs do very well with surgery. The current evidence as of 2013 is that dogs with TPLO do the best. That may change next year. I'm not sure.